Dr. Naim.
Good evening, ladies and gentlemen, and all the members of SSBD, the Saudi Society for Blood Disorders, and all the participants. We are honored to welcome you all for this SSBD Hematology webinar series. Let me without going to the big screen, I'll just show you that we are going to talk about chronic lymphocytic leukemia management in 2020 today. We have very distinguished speakers, a panel of distinguished speakers today. Let me introduce first myself. I'm the chair of the meeting. I'm Dr. Naim Chaudhary. I'm a professor at the Center at King Faisal Specialist Hospital and Research Therapy. I'll be your chair of the meeting today. We have three distinguished speakers, and we'll have a full program for this purpose today. Dr. Clemens Wendtner is a professor of medicine and medical director at Munich Clinical Schwabing, an academic hospital of the Ludwig-Maximilian University of Munich. I hope, Dr. Wendtner, I'm correct. My pronunciation is not that bad. He completed his MD qualification in 1993. He has been associated in this field of hematology, stem cell transplant for a long time. He has special interest in chronic lymphocytic leukemia as a founding member of the German CLL study group. He participates on the steering committee and the secretary of German CLL study group also. The other speaker, Dr. Salim Al-Shamri, is from Kuwait Cancer Center Control. Dr. Salim, would you please introduce yourself a little bit? And then I'll ask Dr. Khalid Al-Ayed also.
I'm Salim Shimri from Kuwait. I'm a consultant hematologist at Kuwait Cancer Control Center. I'm also staff at Kuwait University Faculty of Medicine. I have particular interest in lymphoid malignancies and transplantation.
Thank you, Dr. Salim, for joining us as a speaker today. And Dr. Khalid Al-Ayed, would you please briefly describe your interest in CLL and mute yourself?
Okay. Good evening, everybody. I am Khalid Al-Ayed. I'm a hematopathologist at King Saud University Medical City. I have interest in lymphoma pathology research.
Thank you very much, Doctor, and welcome as a speaker today. Let me just show you briefly the program. The first speaker will be Dr. Clemens Wendtner. He will talk about redefining disease control in chronic lymphocytic leukemia. Our second speaker will be Dr. Khalid Al-Ayed, who will talk on minimal residual disease in CLL, whether that is a new goal that one should aim for. And our third speaker Dr. Salim Al-Shamri, who will talk transplant for chronic lymphocytic leukemia, when and what we have redefined our disease control, even with so many medications now. So where does it an hour and a half, and we'll finish. And I welcome all the attendees. I hope we'll have a good program. This will be recorded, will be available on the SSBD YouTube later on. Please, you can watch it anytime later. You can listen to the whole talk at any time, even on the later. And this will be, I wanted to introduce before I give it to the speaker, that we have an ongoing SSBD web seminars. So we'll have a MENA forum for challenges in hematology on November 30th. We will have on December 2nd, immune-related thrombocytopenia. We will have also a panel of distinguished speakers. So please stay tuned. You can keep these dates for yourself. So let's go back to the program, and I will invite the first speaker of this evening webinar, and Dr. Clemens will stop sharing my. Dr. Wendtner, please go ahead.
Yes, so thank you very much, Dr. Chaudhary, for the nice introduction.
I will try to move on my slides. I would also like to thank the Saudi Society for Blood Disorders for the invitation for this webinar. And so my topic will be redefining disease control in CLL. And you see here my first slide showing the value of minimal residual disease or measurable residual disease. There are three arguments why you should use this in the future. So far, it's not a standard, even not in Germany, but in general, I think there is considerations that this is a very potent marker of efficacy. It better correlates with PFS and OS. It enables treatment decisions. So there are already concepts that we can adjust and tailor treatment length based on MRD results. And with respect to approval, it's a very interesting surrogate endpoint for the regulatory approval. Still, PFS has to be done in order to confirm data by MRD. Now, as told, there is a strong correlation between MRD and PFS, but it's at this point not recommended in routine practice for CLL. And at least for the European Union, I can tell you, it always requires PFS confirmation when we use it within clinical trials. And I'm speaking here also as the secretary of the German CLL study group. So we are doing MRD assessments, but we always also assess PFS for sure. So when should MRD be used to assess response? I think there are three prerequisites in order to use MRD. So the one is, it should be a disease, and CLL is a disease where you have a high proportion of patients with complete remission. There is the necessity also to quantitate MRD assessment. So this is, from a technical point of view, it's easily done nowadays. And we're always looking for randomized trials that demonstrate a predictive impact of MRD. And this is independent of the treatment. So this is an example from the German CLL study group taken out of the CLL-8 trial. This was a phase 3 trial, frontline, randomizing fludarabine versus fludarabine rituximab. And you can see, look at these gray and these dark yellow lines. It doesn't matter whether you have a patient that's on FCR or whether it's a patient on FC. When they have low MRD levels, they have a very good outcome. But the whole truth is the probability to become MRD undetectable is much, much higher on FCR versus FC. Now, this is not the only trial, big phase 3 trial. We have confirmed this in the area of chemoimmunotherapy. That has also been done on the CLL-10 trial. This was FCR versus BR, bendamustine rituximab in frontline CLL. And you also see here the powerful prognostic capacity using MRD in order to predict outcome. Further, the CLL-11 trial of the German CLL study group, frontline trial for less fit patients, was randomizing patients between a treatment of chlorambucil, obinutuzumab versus chlorambucil and rituximab. You see a high rate of almost 40% of MRD negative patients based on flow. This is true in comparison to rituximab chlorambucil, for example, here. And you see that this is really also translating into a better PFS based on the high proportion of MRD undetectable patients. Now, there is also some data showing that MRD negativity is not only impacting on progression-free survival, but also on overall survival. So these are OS curves of patients with MRD undetectable. This is the gray line. The blue line, the bright blue line, shows you MRD intermediate patients, and the dark blue line MRD positive ones. And you see the survival is prolonged once you achieve MRD negativity. So telling us that this marker also impacts on overall survival. Now, this is a recent analysis we actually published also in the New England Journal last year, and this was presented by our group, Kirsten Fischer, at the ASH last year. And you see here two techniques, so an ASO-PCR-based MRD assessment technique and the NGS technique also applied for MRD assessment. So ASO-PCR, the upper curve, and you see end of treatment, this is based on the venetoclax obinutuzumab treatment within the CLL14 trial of the German CLL study group. So after 12 months, we have MRD negativity on ASO-PCR, but also on NGS-based assessment. And you see during the follow-up, so without any treatment, we follow-up 2 years thereafter, all these patients stayed MRD negative. On NGS, because it's a very sensitive assay, down to 10 to -6, you can see a rise already at the end of 2 years. So it's always as close as you look, you know, the clearer the picture comes. But in the end, the message is here, once you have undetectable MRD levels at end of treatment, so this is the red line here, you have a significant better outcome for the patients. This is summarized in this slide. It's a comparison of different trials, and you will see later on some data on the CLL14 trial, so venetoclax obinutuzumab. We also checked the frequency, and you see here we have 42 patients with undetectable disease at a very high sensitive level of 10 to the -6. If you go for 10 to the -4, you see we are talking about 76% of patients being undetectable based on this venetoclax obinutuzumab treatment. That's time-limited treatment for 12 months only. Now, there are other data with other drugs, and the one is the RESONATE-2 trial, a head-to-head comparison frontline of ibrutinib versus chlorambucil. So the primary endpoint was also here PFS. But for a BTK inhibitor, you can't expect MRD negativity in a high proportion. So what you can expect is high response rates in the range of 86%. And you also see that the complete responders are really increasing over time. So after 5 years, you also have with the ibrutinib, this is complete remission and based up to 30% of patients with complete remissions on the ibrutinib monotherapy. Now, a recent approval by the FDA and also by the EMA is acalabrutinib. So it's a second generation BTK inhibitor. And in the context of the ELEVATE trial, acalabrutinib was compared to the standard chlorambucil obinutuzumab. Acalabrutinib was given alone or together with obinutuzumab, and the treatment was followed by acalabrutinib maintenance then. And the outcome of this ELEVATE trial is shown here. So the response rate, you see 94% response with acalabrutinib and obinutuzumab, 85 with acalabrutinib, and 79 with chlorambucil obinutuzumab. But you also see it's only a very small proportion of patients with complete remission and not confirmed complete remission, so incomplete. You see it's a range of 14% only. Now, the CLL14 trial I mentioned before was a head-to-head comparison frontline of venetoclax and obinutuzumab, while the venetoclax was only applied for 12 months versus chlorambucil for 12 months, and here obinutuzumab was also added for 6 cycles. And the trial included previously untreated patients as told, but these were patients with comorbidities. So SIL score above 6 or an impaired creatinine clearance. So just in brief, some patient characteristics. I think it's quite balanced. We don't have time to go through all these data. But I think of importance is MRD assessment is done in peripheral blood before treatment, at interim analysis month 7, month 9. End of treatment was month 12, and 3 months thereafter, and then we performed serial assessments every 3 months. And the bottom line is the complete remission rate for the venetoclax obinutuzumab arm was 50% versus only 23% for chloramicin obinutuzumab. Now, we also assessed MRD negativity in peripheral blood and bone marrow for the VENG, and you see the 76% MRD undetectable levels as assessed by flow. And by next generation sequencing, NGS, we even had also very effective data of 42% I showed you before. But also in bone marrow, that's my point. We have a high proportion of MRD negativity based on flow. So 57% were MRD negative, and this is intent to treat. So every patient was counted. Now, this impacts on the progression-free survival. You see here the 2-year landmark analysis, 88% for VENG versus 64% for chloramicin obinutuzumab. You see there's a risk reduction of 65% with and you see the hazard ratio here. Now, these high proportion of patients being progression-free, I just showed you these 88%, so very similar data. We also know for ibrutinib, you see 89% has been published by Paul Barr for ibrutinib, and for acalabrutinib, you can also see a high proportion, 90% something with acalabrutinib alone or together with obinutuzumab. So a very similar picture after 2 years for the BTK inhibitors. Now, we have recently published the 3-year follow-up data on CL14, so VENG versus chloramicin OB, and you see very similar data. So instead of 88%, now 82%, so quite stable. And the inferior arm was again the chloramicin arm. Here are some subgroup analysis. I think you would follow me that there is not a single group that is not benefiting from the time-limited venetoclax obinutuzumab regimen. So it's across all subgroups a beneficial treatment. Now I would like to introduce another prognostic marker. So besides IGHV mutation status and the TP53 aberration, we now have introduced in the German guidelines a third prognostic marker, and this is complex karyotype. So based on CL14, we have done also subgroup analysis. You see 15% of patients had a complex karyotype in the chloramicin arm, and 17% had a complex karyotype in the venetoclax obinutuzumab arm. And we did survival analysis, and you do see that the complex karyotype group was inferior to the non-complex karyotype in the chloramicin group. For the VENG arm, this risk factor was almost neutralized. You see the hazard ratio is overlapping, so there's no significant difference between both arms. So it seems that VENG, although it's a short follow-up of almost 3 years, but not more, seems to be able to neutralize the risk factor of complex karyotype. Now, what are side effects of the treatment? There were adverse events in the range of 78, 77% in both arms. We are especially have to talk about neutropenia, and you see that especially we're only grade 3 and 4 neutropenia, 53% neutropenia in the VEN-O arm, and 84% in the chloramicin obinutuzumab arm, so quite similar. The good news is the infection rate is not different, so 15 or 17.5% very similar data. We can also dissect this a little bit more. Pneumonia, 4.2%, 4.7%, also similar data between both arms. I would like to summarize and also closing then. So CL14, it's a 1 year, so 12 months fixed duration treatment with venetoclax obinutuzumab. And I hope I could show you that it can be safely administered, especially also to elderly patients, because this was our trial. And these elderly patients have coexisting conditions. It provides a superior PFS benefit versus the standard chemoimmunotherapy, chlorambucil, obinutuzumab. And this benefit is sustained at the last update we did at a 39.6 months follow-up. So this means 2 years after stopping venetoclax. So it provides significant PFS benefit across all subgroups. And I showed you some data. Mutated, unmutated IGHV, deletion 17p, and also complex karyotype, a new prognostic and in this case also predictive marker. So it achieves high rates of MRD negativity as shown, and this correlates with a PFS benefit. Just a very recent update of the German guidelines of the German Society of Hematology and Oncology. I'm the author of this update. I have to write it every year, and you see a lot of changes. And so we are now asking only, does a patient have a TP53 aberration, complex karyotype, or IGHV mutation, yes or not? If the answer is no, then we have these treatment options, a BTK inhibitor, so ibrutinib, acalabrutinib, or one of both drugs, plus minus anti-CD20 antibody. Venetoclax obinutuzumab is also an option. Time-limited treatment is the big advantage, and for the cases with mutated IGHV, we could apply FCR. For elderly patients, the same story here, but then for sure not FCR, but chlorambucil, OB, or BR as a chemoimmunotherapy option. I personally prefer also here for the mutated cases the new drugs. And if you answer the question with yes, so TP53 aberration, complex karyotype, or unmutated IGHV, it's clear it's only a gain between the two groups of targeted drugs. So ibrutinib or acalabrutinib plus minus anti-CD20 or venetoclax obinutuzumab. So there are also these ESMO 2020 guidelines and update. You see very similar data here. The only thing missing is the complex karyotype. So, but this will probably be introduced next year also in the ESMO guidelines. Just in a perspective, an outlook, so CL17 is our new phase 3 trial. It's started actually last week. This is a head-to-head comparison frontline, ibrutinib monotherapy, venetoclax obinutuzumab, what we just talked about, and the new doublet, venetoclax ibrutinib, and this is randomized, and you do see, doesn't matter, fit, unfit, includes also TP53 aberrated patients, so it's an all-comer trial frontline. You just see the geographic pattern. Many countries within Europe are participating in this trial, and we expect the end of recruitment in April 2023 and end of study in 2026. So having said this, I would like to sum up. So treatment in frontline CLL is nowadays more guided by molecular features, IGHV status, 17p deletion, TP53 mutation or complex karyotype, and less by fitness because we are using less and less chemoimmunotherapy. We do have BTK inhibitors, ibrutinib, acalabrutinib, and we do also have BCL2 inhibitors, venetoclax, in this case, plus obinutuzumab. And these are favorite treatment options in the frontline setting. And this includes also treatment of ultra-high-risk CLL with complex karyotype, for example. So the choice of treatment nowadays, I think it will be determined by the potential side effects of drugs. So whether a patient has a kidney failure or arrhythmias, AFib, and things like this. And also the patient's preference, whether the patient wants to have a time-limited therapy or rather wants to have a continuous therapy. So the future studies will explore the value of combined treatment regimens. So I'm thinking here about combos of BTK inhibitors, BCL2 inhibitors, and anti-CD20, and hopefully we will get to a curative option for our patients. Just the helicopter view on my setting here in Munich, and thank you very much for your attention. And I will now stop screen sharing. So thank you.
Thank you very much. This was an excellent talk, Dr. Clemens Winter. We'll have some question and answer during the question and answer session. I can now invite the next speaker, that would Dr. Khalid Al-Ayed from Kingdom of Saudi Arabia. As he introduced himself, he is a hematopathologist who has special interest in chronic lymphocytic leukemia, and especially the minimal residual disease impact on the disease. So from his perspective, he will talk on minimal residual disease in chronic lymphocytic leukemia, whether it's a new goal that we should aim for. And I hope it complements the previous excellent talk also. So Dr. Khalid Al-Ayed, the floor is for you. Thank you.
Yes, just sharing my screen. Okay, just checking. So do we have the slides on here? Share. Okay.
We can see it now.
Okay, good. Just I will put the, okay. Okay, good evening, everybody, and thank you for the society for having me. Okay, I'm going to talk about minimal residual disease and CLL. Is it a new goal or not? I will start with a short introduction on CLL. CLL is a neoplasm composed of monomorphic, small, mature B cells with a specific phenotype. The monoclonal B cells have to reach the level of 5,000 cells per microliter or more. Although SLL and CLL are the same disease, and SLL, the CLL cells count below the 5,000 per microliter cutoff, plus decommented nodal, splenic, or extramedullary involvement. I will skip talking about the clinical presentation. I'll move directly towards the diagnosis. So to diagnose CLL, we start with morphology. In smears, whether peripheral blood or aspirate smears, CLL has its characteristic morphology of a proliferation of mature-looking lymphocytes with rim or very scant cytoplasm, as we see here. The nuclear contour is always round with condensed chromatin. Some medium-sized lymphs may be present. What have been called the smudge cells is a very characteristic feature seen in CLL and peripheral blood. This is due to the fragility of the leukemic cells, and they just rupture easily when do smearing. In tissue sections, CLL has a specific growth pattern by the presence of dark and light areas or zones. We can see here some light zones here, whether it's like very dark here. A feature called proliferation centers. They resemble like a vague nodular pattern. These proliferation centers are formed due to the presence of prolymphocytes, medium-sized lymphs with slightly prominent nuclei, and the paraimmunoblasts, which are large lymphoid cells with prominent large eosinophilic nuclei. The second diagnostic tool for CLL diagnosis is the flow cytometry. Leukemic B cells in CLL has a classic immunophenotype. They are usually positive for markers like CD5, CD19, CD23, CD43, CD200, and light chain restriction. They usually dim to negative CD20, CD22, CD38, CD79B, and service immunoglobulin. Next are additional genetic testing include karyotyping/FISH, molecular, NGS. These are not essential to diagnose CLL, but provide important findings that may help and predict the prognosis or the tumor burden. Among all these techniques, CLL has no specific genetic marker. However, there are common alterations that can be detected in karyotyping or FISH that have an impact on the prognosis. Molecular and NGS testing also could determine whether the IGHV or other common genes are mutated or unmutated. Now moving to MRD in CLL. So what is MRD in CLL? According to the second report of the International Workshop on CLL, patients will be defined as having undetectable MRD negative remission if they have blood or bone marrow with less than 1 CLL cell per 10,000 leukocytes. The blood generally can be used for making this assessment, but we have to be cautious because the marrow will have detectable CLL when it is also found in the peripheral blood. However, there are therapies that preferentially clear the blood, but not the marrow, such as monoclonal antibodies. Therefore, it may be important to confirm that the marrow aspirate also is MRD negative when the blood is found to be MRD negative. The techniques for assessing MRD that have undergone critical evaluation and have become well standardized are MRD Flow, using minimum of 6 colors, flow cytometry. This method has shown sensitivity level ranging between 1 CLL cell per 10,000 leukocytes to up to like 100,000. The second technique is the ASO PCR. The IGHV of the malignant clone is sequenced and allele-specific oligonucleotide probes designed for the specific IGHV CDR3 region. In other words, it is an individual test. The PCR reaction specifically expands the malignant IGHV gene, and using real-time quantitative PCR methodology, the assay is quantitative. On the other hand, it is labor-intense, expensive, and time-consuming technique, and not done like in many clinical labs. The sensitivity of this method is reaching 1 CLL cell out of 100,000 leukocytes to up to 1 million. The third one is the high-throughput sequencing using clonoSEQ assay. This is a novel PCR method using high-throughput sequencing. The patient's clonotype is sequenced at the baseline, and in post-treatment samples, consensus rather than patient-specific primers universally amplify IGHV gene segments, followed by performance of HTS. The malignant clone is quantified algorithmically within polyclonal background, which means the assay does not require validation or to be like done for individual patients. It is the most sensitive technique, and it can reach 1 out of 1 million leukocytes. Among the 3 techniques, MRD Flow is the one that is available in most clinical labs, and I will discuss it more in the remaining of my presentation. Now is why MRD testing is important in CLL. I can summarize that in 3 reasons. First one is the complete eradication of leukemia is a desired endpoint. The second is that prospective clinical trials have provided substantial evidence that therapies that are able to eradicate MRD usually result in improved clinical outcome. And we saw in the first presentation, and now here, this is from the MD Anderson Cancer Center group using FCR as a frontline treatment. and clearly showed that MRD positivity has shorter median PFS and OS as well. Similarly, from 2 studies of the German CLL study group, MRD positivity has a bad impact on PFS and OS. And in particularly in PFS, you can see here MRD negative partial remission. Here, the gray curve actually show better results than cases with like complete remission but still have MRD positivity. In the multivariate analysis on this paper, they have shown that MRD positivity has significant increased hazard ratio in both PFS and OS. Last but not least, there is an increased demand for using MRD at 3 months post-treatment as a clinical trial endpoint. And by using MRD as a surrogate of treatment effectiveness, this would allow determination of the efficacy of the new therapies that are like advances without the need for prolonged observation times, meaning like saving time in clinical trials. But still, until now, this is just only like used in clinical trials. Okay, here I wanna go quickly over the development of MRD flow over the years. So in the 1990s, MRD was initially assessed by 2 markers, CD5 and CD19, and later in the 1990s by adding light chain restriction. This approach was not that sensitive because it only can detect like 1 CLL cell out of around 1,000. In 2007, the European Research Initiative on CLL introduced a 4-tube, 4-color assay for MRD in CLL. This assay can achieve 1 CLL cell out of 10,000. This has made the International Workshop on CLL in their first report in 2008, the next year, to reach a consensus on this assay to be one of the MRD methods for CLL. After that, more advances came out in the flow instruments as well as antibodies. The ARIC in 2013 introduced a 2-tube, 6-color assay. Then 2 groups in 2014 introduced, one group introduced 1 tube, the other group introduced 2 tubes with an 8-color assay. And again, in 2016, ARIC again reported a single tube, 8-color assay in which 6 antibodies are like mandatory for the assay with 2 slots that can be used and are flexible and can be used with a different combination. Again, this was recognized in the second report of the International Workshop on CLL in 2018 as one of the acceptable methods for assessing MRD. Having said that, now I will talk about what we do routinely, like in our clinical practice. This is our low-grade lymphoma panel. We use this routinely for diagnosis and follow-up of lymphoma cases. We collect 100,000 events in each tube, and I would say like our sensitivity level is like between 2 up to 5 cells out of 10,000 leukocytes. So the tubes 1 to 4 are the ones we use for B-cell lymphoma. Tube 1 and 2 are the main one to diagnose and follow up CLL. However, tube 3 and 4 also can be helpful as well in case of atypical phenotype of CLL cases. This is a case was referred to us, known case of CLL for follow-up and assessment. So I will start and walk you through over the tube 1. So we start with the first dot plot here, looking at the forward scatter area against forward scattered height. In this dot plot, we get on the singlets. So we want to make sure that the events that pass like a single events each time, and we exclude doublets or any clusters that might affect our analysis. The second dot plot here, we use the CD45 against side scatter, and this first gate is to gate on the leukocytes, and we exclude the nucleated RBCs and platelets and other debris from our analysis. And then inside this gate, we get on the lymphocyte area to start analyzing the lymphocytes. Here we do the CD45-19 to highlight B cells, and then we move on with the other markers. So our B cells in this specimen are negative for kappa and lambda, and this is like an abnormality. There's no light chain here. And all B cells are CD5 positive. The cells looks negative for IgD. And on assessing the percentage of these cells, so we label these are presumably the CLL cells, and they represent 8.6% of the total analyzed cells. Moving to tube 2, the same, we get on the singlets and then the leukocytes and then the lymphocytes, followed by CD19 positivity and 5. And we find that these cells are partially positive for CD23. They are negative for 34 and negative for CD1C. The same, the percentage is the same because we use the same gating technique. Tube 3, we do not have CD5 here. So we started with singlets, leukocytes, with lymphoid population that is CD19 positive. And we can see here that they are negative for CD20, they are negative for CD10, they are negative for CD38 and 56. And in tube 4, the same cells looks negative for CD79B, CD25, CD180, and CD11C. In our panel, unfortunately, CD200 is like in the 7th, like for a tube that helped to exclude monocytes and any contaminated granulocytes. I actually, myself, I would prefer if CD200 is like in the location of CD1C, but like I usually use it like as a double checking. So comparing from the analysis of the like tube 2 or tube 1 with tube 7, it's like the lymphocytes from leukocyte gate show like I can assume that the B cells are CD200 positive in this case. So this is how we report this specimen. It is a CD5 positive light chain negative B cell population consistent with CLL/SLL phenotype as detected. The expressed marker are CD19, CD5, CD23 partial. They do not express CD10, CD20, CD38, CD43, CD79B, immunoglobulin D, IgD, and kappa lambda. The estimated size of these monoclonal B cells are 8.6% of the total analyzed events, and the absolute clonal B cell count calculated from the WBC count of the patient. So they are around 670 cells per microliter. I will conclude with these notes. Although MRD flow currently is not clinically indicated for general practice, but it is feasible. And to do that, still cellular specimen is needed, as we need to collect high number of cells to reach the acceptable sensitivity level. MRD flow can be done in labs with lab expertise and with the presence of advanced compensation and maintenance QC to provide reliable and confident results. And by this, I have reached to the end of my presentation, and I'll be happy to answer any questions.
Thank you very much, Dr. Ayad. I think we'll move forward with the program, and we'll have some question and answers in the end. And I would like to remind all the panelists, all the attendees, to please put your questions in the Q&A sessions, and I will project them, and we'll have a good debate at the end of the talk. So now what I'll do is I'm going to introduce Dr. Salim Al-Shamri. Dr. Salim Al-Shamri is from Kuwait Cancer Control Center and from the Department of Hematology. So he will talk about stem cell transplant, which should be interesting, especially with given the data that's available on this very effective medication. Where do we stand with stem cell transplant in chronic lymphocytic leukemia these days? Dr. Salim, please, the floor is yours.
Thank you, Professor Chaudhary, and thanks for the Saudi Society Blood Disorders. And I convey my regards to everybody and every colleagues in Saudi Arabia. So I given this task to talk about transplant and about in CLL, given these innovative treatment is quite challenging. But I think it's important we know where we stand in with the transplant. Transplant is based on modeling, selecting patients who are at high risk for death or progression or resistance. And one statistician, his name is George Box, he's actually quite a famous statistician. He said, all models are wrong, but some are useful. And I think that holds true for CLL, because in 2007 and before, we had certain convention about the prognostic features of CLL and who go to transplant and when, and that now has changed drastically. The EBMTR in 2007, they issued guidelines in leukemia, and they basically tried to lay ground for the indication for stem cell transplantation in CLL. And basically, they looked at the data, or available data at the time, and based on the logic. So it wasn't really trials, but it's based on the logic they knew about the disease then. And basically, we do get long-term clinical remissions after transplant. And that has been shown in many cooperative groups. Relapse is actually much less over time with the transplant. Those who get GVHD, they also have GVL and likely to benefit from this immune phenomena by reducing the relapse rate. And of course, there are many studies that looked at this, and some of them actually started with myeloablative. I should say even autologous actually before that, but then also myeloablative. And myeloablative transplant has its own benefit and risk. And yes, it did put a lot of patients in remission. Yes, it did put some patients to a meaningful overall survival and event-free survival. But as you see in red here, the transplant-related mortality was quite high. We are talking about 44% in the IBMTR group, and in the international project was 31%, which is actually exceeds the cumulative incidence of relapse. And that approach is slowly actually abandoned because we have something called reduced intensity, mostly based on fludarabine or reduced dose of TBI. And with the aim is to reduce the transplant-related mortality, hoping that you don't kill that many patients in the transplant, and you give the GVL effect to take over and reduces or result in meaningful overall survival. And yes, it achieved. There are many studies from Seattle, EBMT, Spain, and you could see the transplant-related mortality has dropped, at least in the 2 years in the transplant, of to 19%, for example, in the registry data, as well as in the Seattle group, 22%, almost half of what is seen with the myeloablative transplant, and resulted in event-free survival and overall survival, at least in the first 2 years. But we know the nature of the disease. It is indolent. The patient can even survive longer. So the 2 years sometimes may not be meaningful, but I will share with you some data in the coming few slides about long-term follow-up of these cases. So the ABMT suggested that, fludarabine resistance has a bad connotation, and those who resist the fludarabine, and I believe some of these data even before the FCR data. So it has a connotation of high risk of relapse, and resistance. Short term of response, so less than 12 months, so were found to be an indication for aggressive disease and poor outcome after cytoreduction. Patients who do not achieve complete CR or complete response of fludarabine, even if they achieve the meaningful response. Of course, the other data like 17B deletion, high degree of homology for unmutated IGHVs are 70 and CD38. So the group recommended and say, well, in summary, we recommend doing transplant, allogeneic transplant, reduced intensity, to those who have urine analog resistance and they failed early or within 12 months. Those who had P53 abnormalities, and of course they needed to be treated. And those who relapsed early, like 24 months, but then those who were already given intensive treatment, even autologous transplant, they thought, and maybe if I think in those days, probably many patients would have gone for transplant, which makes sense because most patients will relapse if they are not given chemotherapy. Many patients, now we know they are almost half of patients can be IGHV mutated and they don't respond to chemotherapy. And some patients actually have P53 mutations, so especially when they relapse, it goes from 10% to 25% in relapse. So that was their indication to, but now we know, transplant has risk of morbidity and mortality if we compare it to any other treatment, especially nowadays with the novel treatment. And actually, since 2007, there has been no consensus about the indication for transplant, simply because of the changes in the biology and treatment advances in CLL that resulted in improvement of outcome. So, I always say we should not be just adopting or copying data from published international, but we should apply these models to our patients, because I believe we have some changes in the biology of the disease. Our population tend to be smaller. So I followed this disease for some time. One effort is to look at the biology, one to look at their outcome, and also maybe see how, as a transplanter, we like to explore other options before we take any patient to transplant, given the complexity of the procedure and its long-term complications. This is well published in the literature. Older age with comorbidities, they fare worse, given that they cannot tolerate intense treatment. Of course, you cannot take many of those to transplant, and we know those patients need a special approach, maybe avoid even chemotherapy at all. Males tend to do worse. Those with high beta-2 and high IBI for CLL. Of course, the notorious 17B deletion, 11q seem to also fare worse, but that is now fairly controlled with chemotherapy. Unmutated IGHV and complex KARYOTYPE, as already mentioned by our Mr. Speaker. So I looked at our data, and this is a cohort of patients. You could see the median age of 59, which is almost 10 years younger what we see in the Western countries. Majority of our patients below age of 65% actually below the age of 65. And interestingly, that 31% are even below the age of 55 years. And that is not usually seen in Europe or Western countries. I think there is a much higher, our number in terms of those who are younger, much higher than what is published in the literature. But you could see, we see patients as young as 28 years and as old as 90 years. And the logic is there that these two extremes, they have different approach for management. Most of our patients, like everybody else, they present at early stages, like race stage 0 and 1, or Bennett stage A, and a lot of those are kept under wait and watch without a specific, without starting any treatment. Dr. Khalid already mentioned about the cytogenetics, and I looked at those in our patients. Deletion 13q, which is usually have a fairly good prognosis, is in 31% of our cases. The notorious deletion 17B is only in 4%, which is actually quite low than published in the literature. I think in the literature, upfront cases is 7%, 9 or 10%, and of course, that relapse is much higher. So I also looked at the mutational status in our cohort, and IgHV unmutated, and that is a homology between the normal Ig immunoglobulin and the patient immunoglobulin. So if it is similar 98% of the time or higher, 98% or higher, this is unmutated. And in the literature, it's quite well documented. Unmutated, they fare worse. Even with chemoimmunotherapy, they still respond, but they tend to do worse than unmutated. And there is an agreement now, they should not be, although we still sometimes we give it, they should not be giving chemoimmunotherapy. We should proceed to targeted therapy. So in our data is 51% of, and I believe this is similar to what has been published in the literature. If we look at the immunoglobulin subtypes, I mean, this is again no difference. IgHV 1 to 69 and IgHV 4 and 34 are also are the higher, and that's what is documented in the literature. So our patients do not seem to be different when it comes to immunoglobulin structure. This is a very recent paper in October 2020 published, and actually now these cells react to antigen. They have a certain complementarity determining region, and they are stereotyped. And when they looked at the stereotype, this happens almost in 30% of CLL cases. And the stereotype, whether it is mutated or not mutated, can have a different outcome. So if the patient is mutated, and we would expect they do well in chemoimmunotherapy, those stereotypes, for example, subset 2 and subset 9, they fared worse. So those patients maybe in the future be considered to alternative approaches as opposed to just chemoimmunotherapy in those patients. So you could see most of our patients did well. Death in those patients not very high, and we had patients who have been followed for like almost 60% are followed at least minimum of 2 years to 10 years, and they do quite well. And so the period followed, 95% are alive. I mean, I did not talk here about their management, but most of them did not treatment. Those treated did well. And we had a few deaths, a few disease progression or rectal transformation. And would not feel they could have benefited from transplant at the time. So now this is just a general model for our patient. We could see the group of patients we see they are low intermediate risk. Some are high, but very few. So the role of transplant usually deferred until for our patients. So I thought to review the transplant and the published and learn lessons from the past. Transplant has been used, of course, for some time, but there's nothing in the literature that randomized the clinical trial between transplant and any other conventional or innovative treatment. It is done based on a specific indication at the time of the studies. Actually, there are even no trial that compared reduced intensity and myeloablative, just because the community thought myeloablative is too toxic. Let's go to REC and see what happens to those patients. There are a few studies in retrospect looked at outcome transplant versus no transplant, but these were not like a comparative randomized study, they're just historical controls. This is one paper from Dr. Dibaja, and you could see the transplant mortality is 22% in the transplant arm compared to only 8, but the transplant gave you a longer life expectancy of 35 months compared to 25 months. This is another publication, I believe in 2014, but the study was old. And they looked those who referred to transplant. I believe this is from MD Anderson, and those who had, what do you call it? I believe from MD Anderson. Yeah, and they looked at patients with donor, no donor. So those who had donor and went to transplant, they fared better than those who did not have a donor and not did transplant. Third study is Michael Boone. Sorry, this is the one from MD Anderson. Those who referred as a consult for transplant and eventually had a transplant, they seem to also do well, with a 2-year overall survival of 64% compared to 25% those who did not have transplant. But as I said, those studies are retrospective cohort, they are short follow-up, and it's a mixed bag of different population of patients. So in no way you could make certain conclusions. And many of those patients are old cohorts, so the biology of the disease is different, and treatment before the transplant was also different. These studies, I basically, the one with the longer follow-up, so minimum of 6 years, some of them a bit, I think 5 to 6 years, from a group like Fred Hatchner, German study group, and MD Anderson. And you could see the median progression-free survival 6 years is only 39%, for example, the Hatch group, which is quite low what we saw earlier studied at 2 years, which means patient dying from complication or patient dying from relapse. This is a German CLL study, and it's also a long follow-up, but they also looked at specific biomarkers. For example, Notch1, SF, slicing factor beta leukemia, 3-beta-1, TB53, and deletion 17B. The message is those biomarkers, those negative predictive biomarkers, their effect is abolished by transplant, whether it is TB53 or any other notorious biomarkers we know in CLL. Interestingly, which already alluded by the two speakers, that MRD negativity is a prediction of long-term survival. The interesting thing, it is the 12 months MRD negativity after transplant. Those, even those who achieve MRD negativity later some of them still might relapse. The BMTR, I think they also looked at their data. This is one of the largest transplanted CLL cases from 2000 to 2010. So it is the area where transplant was still popular. And they tried to look at the outcome at 2 years, 5 years, and 10 years, and they compared to the general population, given that CLL is a disease of older patient. And they also look at male and female gender as an outcome. You could see the 2 years overall survival of the whole cohort is 62% at 2 years, but then dropped to 35% in the 10 years time period. You could see in the red dotted line, non-relapse mortality is still very high. It's actually even worse than relapse. So still patient dying from the procedure as opposed to the disease itself. This is likely due to GVHD and poor immune reconstitution and immune suppression, and all that would contribute, of course, to worse outcome. I mean, I tabulated this between the different endpoints they studied, the overall event-free incidence and relapse. You can see mortality goes up, incidence is low, but still there. And the 1 year overall and event-free from 71 and 62 drops to only 35 and 28%. And this graph shows you the mortality compared to the general population. So for example, in males at 2 years, 8% are dead compared to 1% to the healthy general population. And you can see the 63% and 92 at 10 years. And this applies male and females and younger age group and older patient group. So transplant does contribute to mortality of CLL patients and in significant way. Same group, they actually looked at younger patients, like less than 50 years, which we all think they are the transplantable patient population who can tolerate a lot of toxicity of the drugs. And they showed that those patients the 2-year progression-free survival of 55 dropped to 38 at 8 years. The cumulative incidence of relapse is 25% and 39% at 8 years. You could see the immune effect of transplant is quite effective in those with deletion 17B, and whether patient mutated or not, they still do they do well. This is what they did. Risk factors or multivariate Cox regression to see which parameters affect the outcome better or worse, basically. So the non-relapse mortality is quite affected by the HLA disparity between the donor and the patient. So the mismatch when are related, they fare worse when it comes to mortality from the procedure, which is expected because they get more chronic GVHD in terms of incidence as well as in severity. For relapse, prior autologous predicted worse outcome. So patients relapsing after, if they had already auto-transplant before, or they did not achieve remission before the transplant. And when it comes to progression-free, you could see all the 3 factors affected the BFS: the prior transplant, remission status before transplant, and actually disparity between donor and patients. This is represented in the graph for the German study group, which is a long follow-up of which I already showed you earlier. And you can see they have the 10-year progression-free survival of 34% with an overall survival of 51%. Transplant abolished, of course, the negative impact also of the TB53, and there is no difference in BFS or overall survival between these 2 factors. And this is the MRD negativity. So early MRD negativity predicted favorable outcome of those patients who had an allogeneic transplant for that. But this is the past, and we know CLL improved outcome with a current novel therapy. We have a ibrutinib, we have a acalabrutinib, we have venetoclax. They affect great spectrum of CLL patients. Those with even the notorious P53, they can do well. This is a ibrutinib, the Resonate 17 trial, and showed that, still, I mean, you could see that in the past, this patient would not continue 12 months before they actually progress and maybe die from the CLL. But now you could see these long curves, and of course, ibrutinib use even in non-B deletion, they did quite well and became the standard of care for those cases. For relapsed refractory CLL, you could see the Murano trial and this combination of venetoclax and rituximab, they did quite well. And so did that impact our practice? Yes, it did. In Kuwait, for example, we are switching from ibrutinib. Well, FCR was our, but dropped now by 68% from, for example, 2006-2014 period to by 68%, and target therapy like ibrutinib, and now we have other options they are picking up for because the data on the ibrutinib came in the second line or relapsed refractory. We went to target therapy like ibrutinib. So we still not fitting the transplant in these patients because we believe they can be saved the toxicity of the transplant and maintain a good quality of life with reasonable event-free survival. So all these novel therapies has impacted the practice for transplant. And you could see the data from the ABMT, the United States, picked up from the early 1995, 94, and you can see the hump that in the mid-2000s. And of course, we start to see the approval of this novel therapy in the 2014, I believe, 2013. And that is drastically affected the activity of allogeneic transplantation of CLL for, of course, the obvious reasons. Now, eventually, I mean, are these novel therapies just delaying relapse? because we know they don't cure patients. So that is a given fact. Yes, they control the disease for a long time with a good quality of life. But I think eventually something will happen. They will be refractory. And so this paper published in August 2020 in Blood Advances, again, it was a collection of cases who failed novel therapy, and they went to transplant. And the primary objective was to look at progression-free survival and overall survival, what factors could affect those type of patients, and did actually novel therapy affect the outcome of transplant. This is the cohort of 60 or 65 cases. You could see they are pretty much high-risk patients, TB 53, 51%. Many also had the aberration 17B, complex karyotype. Most of those patients had unrelated transplant. 95% they had reduced intensity. Very few had myeloablative. And the typical GVHD prophylaxis with calcium urine inhibitors and methotrexate. This is the patient demographics, what treatment they had. 82% had prior protinib to before the transplant. Of course, some had venetoclax, some had even both, and some switched from protinib to venetoclax, but typically some of them actually had chemo-free, so they never even had chemo. They went from protinib to venetoclax, then to the transplant. And that's what they reported. BFS, median BFS was 63%, 24 months, and overall survival of 81 and the cumulative incidence for relapse at 24 months, that's 2 years, 13%, sorry, mortality is 13% and relapse is 27%, which is a bit different what we saw in the area of studies, because mortality was higher than relapse. And in univariate and multivariate analyses, you could see what stood up in the univariate was the hematopoietic, hematopoietic comorbidity index. So the higher, the worse, and also donor related, not related. But when they went to the multivariate, it's actually the HCT was the most important. So if they have a score of 0, that is they are fit for transplant, the comorbidities, they did very well. But if they scored 1 or higher, the outcomes seem to be inferior. And this is represented by this graph. So you could see the BFS here with the 0 HCT score did quite well. This is just stratified by, well, they have protinib, then went to venetoclax, or they have chemo-free, or all that did not seem to affect outcome. All those patients fared well, were equal initially, they fared equally, regardless what they had before the transplantation, which probably says, okay, if your patient failed novel therapy and you want to take him to transplant, you shouldn't worry about what treatment they had before the transplant.
Dr. Al-Shamri, okay, so please, we need to conclude now.
Yeah, I am concluding. So CLL prognosis is changing with each novel treatment. Transplant is basically declining, and I expect might be another rise in the coming 5-10 years, but maybe I'm probably will not see the hump we saw in the 2000s, simply because the patient population will be older, and then probably there will be newer agents, and probably there will be more people going to clinical trials. So these things probably will affect the transplant. Now I think those who failed lines, these novel lines, might be the only patient indicated for transplant. Thanks for listening.
Thank you very much. I really appreciate it's a great effort by all the speakers. And thank you very much for an excellent presentations from Dr. Ventner, Dr. Ayed, and Dr. Al-Shamri. What I'll do is I'll open the floor for the questions. What I can do is I can project the 2 questions that I have, and maybe the panelists can take over the first question that relates, I think, to Dr. Al-Ayed. There is a question from Dr. Samir Al-Amoudi. He says, is there any discrepancy in when you measure MRD for CLL between peripheral blood and bone marrow? Or is there any preference?
Well, I mentioned. Yeah, I mentioned that. It is recommended by the International Workshop on CLL that blood can be used, but in case of cases that treated with monoclonal antibodies, they might have a cleared peripheral blood with still bone marrow aspirates that can have or can be CLL cells can be detected. So in case of monoclonal antibody treatment, you can do blood, but confirmation with a bone marrow testing is recommended.
Okay, thank you very much. There is one question, and I think anybody can take on the panel. Somebody's inquiring about whether CLL, are they COVID-19 vulnerable? If somebody is chronic lymphocytic leukemia, whether on treatment or without treatment, would they be considered as a high-risk group? I think it's true for all hematologic malignancies, but is there any taker? Dr. Venter, would you like to answer on this one? Is the CLL by itself is a high risk for COVID?
Yes, unfortunately, we also do see problems in CLL cases acquiring COVID-19 infections. There was a recent recommendation by ASH, and the recommendation was that especially looking for treatments on an outpatient basis. So this argues for the use of BTK inhibitors especially. And there is some put in lines by ASH, some precaution about the use of anti-CD20 antibodies, because this can further, make the disease or the acquisition of COVID-19 difficult. So that's the official recommendation by ASH. We checked our own trials by the German CLL study group. Difficult to tell. We had some cases also on CLL13 trials. It's venetoclax plus anti-CD20. Altogether, we have 7 cases of COVID-19. 2 out of these 7 patients died actually. 5 survived. But in answer to your question, yes, I would say also CLL as a vulnerable disease with respect to COVID-19.
Okay, so just from my side, just to make it a bit more elaborative for the purpose of the audience also. So let's say if there is a new patient with CLL who requires therapy, but it's not really very symptomatic, but you are going to start therapy and it can be delayed for 3-4 months. And since there is a second wave of COVID right now going all over the world, actually, would you consider delaying the therapy if the patient is otherwise stable, or would you proceed with it at the present time with all the precautions and everything, or would you consider delaying if it's possible for 3-4 months?
Should I answer? Or?
Yeah, please.
Yeah, thank you. So if possible, I would delay the treatment. If there is an urgent need, the patient has to be treated. This would be my answer to your question. In Germany, right now, we have a peak wave with respect to COVID-19. So in Germany, we have roughly 20,000 new cases per day. That's quite a lot. We are expecting that this wave will decline in the next few weeks due to a second lockdown until end of the year. So if the patient is able to, live with the CLL disease for the couple of next weeks, then I would delay. Otherwise, I would go for an outpatient treatment, preferable in this case, BTK inhibition.
Yeah, okay. So that was my next question. So in case if there's a choice and there's no, but you need to treat, would you consider chemoimmuno or the BTK inhibitor? So the preferable choice, and we have done the same. I have done the same also. Used the BTK inhibitor rather than chemotherapy, trying not to get the patients into neutropenia and reactions to rituximab or obinutuzumab. So going to some further other questions also. to Dr. Ventner, can I ask another question? Is that, let's say if there is a patient, a young patient of about 40 years of age, he's in mutated status, not unmutated, so it's not really a high risk as such, and no high risk chromosomal abnormalities like 17p or deletion 11q23 or complex. Would you consider still a BTK inhibitor or a venetoclax 2-year time-limited therapy, or would you consider just 6 months of FCR for that patient?
So I give you a very honest answer. So our guidelines would allow for FCR in a 40-year-old mutated, IGHV mutated patient. That's the official guideline. But meanwhile, we have shifted in daily practice on time-limited treatment with venetoclax obinutuzumab, because this is allowed by the German guidelines, even for mutated cases. And we can draw some conclusions from CLL14. Very recent data showed that even with a mutated IGHV status, the outcome is better for VENG compared to chemoimmunotherapy. In this case was chloramicin obinutuzumab, so it's a little bit different chemoimmunotherapy you would not consider for a 40-year-old. Yeah. But just telling us that new drugs also might have a benefit even for the better prognostic group of IGHV mutated cases.
Okay, I'm getting your opinion on the same subject. Let's say if there's a question arises that if there's a patient who's above 65 or close to 70, but does have comorbid conditions like hypertension or ischemic heart disease and a risk of atrial fibrillations or anticoagulation, all these things. Do you think the chemoimmunotherapy is completely out? Would you consider giving that patient a time-limited, for example, bendamustine, obinutuzumab or bendamustine rituximab, rather than putting on the BTK? Now, this is, I'm talking about specific because we do have these kind of patients where there would be high risk because of the underlying comorbid conditions. What would be your opinion on this, your choice or your opinion?
Yeah. As you pointed out, the BTK inhibitors is a problem when you have a lot of comorbidities, in some cases arrhythmias, bleeding disorders and things like this, patients being on DOACs. We have performed the venetoclax obinutuzumab trial, especially in comorbid patients. So the median CILS was the highest we ever had in our trials. It was 8, so 8 points. That's really a comorbid patient. And so if the patient doesn't have a renal impairment, so that's the only thing I would exclude, then I would also go for a time-limited venetoclax obinutuzumab frontline treatment, because the argument for chemoimmunotherapy could only be time limitation, but we have the same advantage now with venetoclax obinutuzumab when we are talking about frontline therapy.
Fair enough. So let me ask a question, Dr. Salim Al-Shamri. The same, let's say for a young patient with 17p deletion and you decide to give this patient ibrutinib or venetoclax obinutuzumab and look at the MRD and MRD becomes negative, would you consider at that time, since the patient is only like 40 years old, would you take the patient to transplant, or would you take the patient if there's a relapse?
Yeah, I mean, of course, as we are showing the data, very quite uncommon, the 17p deletion population. In our population, we discuss it always with in our group, and there's always the argument. Sometimes as a transplant, I should go to transplant. The other side, you said, no, he's responding, let's wait. And that happened only 1 or 2 cases. So if they are responding, we do not proceed to transplant as a consensus group in our. But also some of those who progressed after novel treatment, they were in a bad shape, not fit for transplant. So it's not an easy decision. And so some of those patients also older patients, so they don't have a donor. So these also competing risk to prevent us from taking them to transplant. I think I still believe those who are 17p deletion, they failed novel therapy, including Protilib or Venetoclax, should proceed to transplant. This is their only chance.
Okay. So as a follow-up to the same questions, and it's open to the whole panel, would you consider, if you do take a patient with a high risk, like say 17P, and you take them to a stem cell transplant for whatever reason, whether they didn't respond very well, but once they go through a transplant, would you consider any factor for purpose of use of, let's say, Brutinib that you used as upfront for induction to cause remission, and then would you consider as a maintenance therapy post stem cell transplant to reduce the risk of relapse? Or is there any benefit? Is there any data for that? Because taking this data out of the chronic myeloid leukemia patients who went through allo stem cell transplant, especially in advanced phase disease, there is a general recommendation to put them for 2 to 3 years on a maintenance therapy post stem cell transplant. What is the role of maintenance therapy in post stem cell transplant in CLL for these high risk patients, especially with these BTK inhibitors?
Yeah. No, I'm not sure if there's enough data to support that. I mean, patient either unfortunately they die from the complication, or as the data shown, even in the recently published paper in Blood Advances, this was not a strategy people utilized in trying to keep those patients in remission. So to me, that is not the case. I mean, saying that, I have a patient who actually had a CAR-T for CLL in the state, and they send him home with a Brutinib as a. So I had not argue with. I mean, he's my patient, and he's also being followed in CHOP. So I wasn't convinced, but I told him I will keep it because I don't know if this is unpublished data or just a personal choice of the physician.
Or maybe because it's an autologous, maybe it's possible that they may have just contributed to it. Now, for the question of MRD, it's open to the panel and to Khalid Al-Ayed also. Normally, when we start therapy, we do a bone marrow. Normally, at the diagnosis, a lot of us do not do bone marrows unless the time comes for the therapy. So let's say if you document MRD negativity by bone marrow at the time of short time limited therapy, whether venetoclax or obinutuzumab or venetoclax rituximab or FCR, would you then subject somebody to bone marrows as a follow-up, or would you just consider a peripheral blood for monitoring of MRD negativity as a follow-up?
Well, if it's, go ahead.
Go ahead, please.
Well, if it's like in the period 3 months after completing the treatment, you can do either like peripheral blood or bone marrow. So answering your question, after 3 months of completing the treatment, it is acceptable practice to do it on peripheral blood.
If I may comment, so I would.
Yes, please.
So actually, thank you. So I would agree with Dr. Khalid. So we have actually checked this on our CL14 trial population. So Van-Obi, and so the monitoring every 3 months peripheral blood versus bone marrow. And actually, there was no real difference. The only thing is that patient denied being punctured every 3 months. So, so the frequency of samples went down. But in the end, with respect to prediction of PFS and things like this, there was no difference. So it seems that with these very effective MRD-inducing therapies, like venetoclax-based therapies, there is not a big difference. So you could go along with peripheral blood, as Dr. Khalid said.
Yeah, that's you're right. CL14 did publish that, and I looked at it. So I will just ask for a last question, and Dr. Wender, this from you. Now, when you look at the model of chronic myeloid leukemia, now when imatinib came and other TKIs came, they said, well, this is a lifelong therapy. But eventually they realized that once patient becomes MRD negative or go into a deep molecular response or deep therapy, they do tend to stop them, and some of them remain without therapy for many, many years. Do you think, I'm talking about ibrutinib now, not about venetoclax, obino, or venetoclax, because that's already time limited. But if you start patient with ibrutinib and the patient goes into really a deep undetectable MRD or deep molecular response, would you consider, or should we put this as a trials, or would you encourage people to go and take them as multi-center trials or investigator-initiated trials to look at the treatment-free remission in this disease with these BTK inhibitors now?
Mm. So it's a very good perspective and also projection from your side. Actually, the German CLL study group has exactly asked this question. So the CLL13 trial included one arm, and this was actually a triple combination based on venetoclax, ibrutinib, and obinutuzumab. And the ibrutinib duration was based on MRD assessment. So we put the patient off ibrutinib once the patient got MRD negative, and then every 3 months, MRD assessment was done on peripheral blood. So the data are collecting right now, so we're not able to show it now at ASH. We have to wait a little bit longer, but exactly your trial question has been addressed, and there are other trials by the UK group, by the MD Anderson, asking also this MRD-tailored treatment and stopping in between the drug holiday. I think that's the approach we really should take for our patients.
Thank you. I think this is good news. Hopefully the results will be good, and so patients would have some reliance on that. There is always a chance that they could stop medication even for a short period of time to reduce the risk of complications. Once again, I thank you all of the speakers, and I will just take this opportunity to thank all the attendees, especially who we have about more than 200, almost 262 attendees or 270 attendees today. It's a big number. SSBD is the largest and the only society that is a national society of the blood disorders in Saudi Arabia. And we have a large number of members. I will just also just put the screen to remind everyone that we do have the further seminars coming up. And that would be I think it's not allowing me to go down, but we have webinar on the 30th. This is it. MENA Forum for Challenges in Hematology, Multiple Myeloma. We have Dr. Philip Moreau from Nantes, France, Dr. Fahd Sharif from King Faisal, and Dr. Maria Metis from Salamanca, and Dr. Saud Al-Haili from King Faisal also. Please do attend. It will be an interesting talk and a webinar. And then after that, on the 2nd of December also, we have immune-related thrombocytopenia from Dr. Ali Al-Samkari from Harvard University, who will be our keynote speaker. Then Dr. Hazal Zahrani, Dr. Masool Al-Jabri, and Dr. Amir Aleem from the University Hospital here. So please do attend all our webinars. And once again, thank you very much for all the speakers. I really appreciate your time, taking time out, and for your excellent contribution with your talks and your question answer session. Thank you very much. I'll call it for a close now. And thank you very much. So we will leave.